Okay. Good evening, everyone. Welcome to the 11th series on weekend wellness. Today's presenter is, we call him Teja, Naga Vemparala, Aditya Teja. So Teja is easy for us. So he's a classmate of mine, 97 physical therapy batch. And he's been practicing physical therapy mainly in manual therapy, and also he has a lot of experience with kids. You can see the first slide actually. Basically, he has a lot of experience with breathing exercise and treating patients with scoliosis and everything. And he has done his master's in Quinnipiac University, Connecticut, and he has done his manual therapy MSPT in 2006. Of course, he has done his master's of physical therapy in Hyderabad. Bachelor's he did with me in Ramchandra, and he has officially been completed his course with Mackenzie Institute. I think he took a break from his work to finish it last couple months back, and also done his Maitland concept on manual therapy. So very happy to present Aditya Teja. Uh, he's going to talk on functional exercise for breathing. Here you go, Aditya Teja.
Yeah, thank you, Ramki, and welcome everyone. And it's very exciting to meet you all online. And this is one of my first presentations in a long time. And at this pandemic time where everyone has trouble with some sort, I thought a presentation on functional exercises for breathing would be appropriate. And let's see if I can explain few things how it can be useful in your daily exercise routine or your fitness and conditioning exercises. Okay, so the goals and objectives for today is to help and educate people for breathing exercises, and also from learning from all my peers and my fellow practitioners, and also learning from patients, because not everything is learned in school or learning from a book. Most of the time I learned more when I was in the clinic working with the patients. I was able to see a lot more different syndromes and different signs and symptoms, and different methods that I was able to use and see if the efficacy of these strategies working with the patients. So I did learn a lot from working with the patients than just learning from school. So my disclosure, all the material that I have been presenting today is primarily from Crystal and Arshrat's textbook of three-dimensional treatment for scoliosis, where they mentioned extensively about rotational angular breathing, and also some from the Martha Haas scoliosis and human spine, and also a few techniques that I also learned from Mary Masri. If you can't breathe, you cannot function. So these are the three resources that I have taken my concepts for presentation today. Okay, and yeah, that's my professor, Miss Hagit Bedevsky, where I got my training from, and she was my Shroth instructor and professor who taught me everything regarding scoliosis and pediatric rehabilitation. And just briefly going about the history, how this all started about rotational angular breathing was from Katharina Schroth Clinic, which is located in Germany. So in 1920, it was a method that was started by Katharina Schroth, where she initiated treatments for scoliosis patients using a three-dimensional correction techniques, and incorporated rotational breathing method to treat those patients. And then her daughter, who is Crystal Lennart Schroth, on the right side of this slide, she further improved the concepts of rotational angular breathing and improved the concepts on the Schroth method. Then These are the pictures that are taken from the newspapers about how she was treating general public who had spinal deformities. It shows using active exercises and breathing techniques to help come over the problems and disabilities of spinal deformities and breathing difficulties. So these are the methods where active exercises and breathing techniques would help in control of disability and also for pain control. So this method is entirely active. It's an active exercise technique rather than any kind of passive modalities or any passive techniques. 95% of the techniques are patient generated forces where patients are able to change their posture and incorporate breathing technique into their routine to help come over the disability or any impairments of the chest or for any kind of breathing disorders. Um, so this is an active approach, and there is a very minimal, if there is a need for a clinician application of forces, then definitely there is also a chance for the physical therapist or the clinician to help assist the patients with improvement of their breathing technique. Again, Dr. Manuel Rigo, he's the current director for the Barcelona Scoliosis for Physical Therapy School, where he teaches physiotherapists all around the world. And they do training in English and also in Spanish. So he's the main director of Barcelona Scoliosis for Physical Therapy School. Okay, so today, when we are looking for, when we are doing the assessment for respiratory evaluation, in the context of a orthopedic patient, like say, for example, patient is coming for scoliosis or kyphosis deformity or Schoorman's kyphotic deformity. Um, the method of doing the respiratory assessment is in this following method, where we are doing the posture evaluation, where I'm looking for shoulder height, pelvic obliquity, neck and head position, then weight bearing strategies of the lower extremities. Like if I'm trying to see if there is a weight bearing on one leg more than the other leg, or if there is equal weight bearing. Then I'm looking for spinal or any kind of chest deformities. Then I would also examine the range of motion, flexibility, any kind of rib humps, prominences, and then I would also look at the kyphosis and lordosis, any kind of deviation, whether it is hypo or hyper kyphosis or lordosis. Then I would go on to do the radiological evaluations if we have a chance to the patient's X-rays. Then going on to observation of general respiratory pattern, I would see in supine, sitting, standing, and then also I would be able to better assess, like if I'm able to see if the patient has any barriers with the exercises, and that would let me know what positions are the best ways for me to give the exercises for these patients. I would also be identifying a pattern, like whether the patient is primarily doing upper chest, or he or she is primarily doing intercostal mostly, or diaphragmatic, or paradoxical. So I would not look at them very consciously. I would rather, because for most of the patients, when we examine the patients without their shirt on, they would get very conscious. So it should be done in a friendly and a relaxed environment where you're able to identify the pattern. So in that way, you will be able to understand what are their mechanics in breathing. You can also continue with taking the vital signs, blood pressure, respiratory rate, pulse, heart rate, all the general things that you would do in a normal orthopedic eval. Then for objective measures, then I would go on to take chest expansion by using a simple measuring tape. I would go on to take at multiple levels, actually, which are like subaxillary. Then second one is at xiphoid. Then the third one is at the level of the 12th rib. And fourth one is at the level of umbilicus. For more stricter objective measures, you can also use a caliper. Depends upon the patient and their comfort, because some patients, if they're very stressed or if they're feeling anxious with the objective evaluation, then I would keep it as simple, because I would like to have the patient more relaxed and comfortable rather than being nervous and stressed. So in that way, we can, it will be easier for us to bring a good rapport with the patient, and then go on, and then in later subsequent assessment sessions, you can go for more objective measurements. You can also use a spirometer, which would help you to give you some objective measure of how much the volume of air that is done in expiration. So this is one objective measure that I would be using. Then the latest options for us to objectively measure the spinal deviations or any kind of chest deformities or any kind of pelvic asymmetries is to use of Dyer's 4 metric, where it is completely non-radiographic, and there's no radiation and there are no markers used, and it's completely contactless. There is no touch by the therapist on the patient, where you're just shedding a light on the patient, and then you would be able to get a lot of more than 20 to 30 objective measures by using this latest technology, which is called as Dyer's 4 metric. For all my patients, I would take photographs in all the four angles, like forward, sideways, and posterior, to understand their posture. So using a postural grid in the background would be a good thing to have. Then coming to the treatment, I would say posture correction. Then I would go on to do the respiratory breathing exercises, because if we don't correct the posture before breathing exercises, it would not be very effective. So in the posture correction, again, it is divided into two kinds. First one is minimal corrections, using very low tension postural balance and alignment of pelvis and lower extremities. And then after the patient is able to achieve the minimal corrections, then I would further go on to do the maximal possible corrections with that patient. So, which are more specific to the spinal deviations or any kind of chest deformities they present. So the maximum possible corrections are specific to each patient, and we use a very high tension and hyper correction techniques or over corrective techniques to stabilize the posture of the body. So the posture correction is very specific to the specific classification of that particular patient based on their presentation. It is not the same principles of correction for everyone. So the postural correction is based on the classification that the patient presents. And again, in the principles of correction, we use techniques where auto elongation, and then go on to correct sagittal and in frontal planes. And then we finally use the reshaping of the trunk to volume control with breathing mechanics. So these are the three small principles that we use for correcting the posture and also the breathing technique. So this therapeutic exercise method, which is called the Schroth method, we use active therapeutic and functional exercises where we are using cognitive, sensory motor, and kinesthetic training to teach the posture correction and breathing technique. So it is an active involvement of patient to correct their posture and improve their breathing technique. So in this slide, you can see how the patient is able to actively involve in spinal elongation, where it creates a perfect opportunity to help improve their breathing technique. So it is much appreciated where the active movement is much more better than passive ones to learn the neuromotor behaviors. So in my view, when you actively involve patient with active exercises, the outcomes will be better because the patient will be able to understand what they have to do once the patient leaves the clinic and when they go back home. So they have the tools and they understand the technique of the exercise, so they know how to perform the home exercise by themselves. So what are the indications for the Schroth method? Primarily for juvenile and adolescent idiopathic scoliosis. And a few techniques can be used to treat in adult and geriatric scoliosis patients. And it can also be used in treating sagittal plane deformities such as Scheuermann's and or inverted back conditions. And very rarely, I also use it for post-op conditions, which require some postural correction with breathing technique. And also, if an adult patient who was treated conservatively for a long time and they didn't have any surgical repair, and if they present with painful or degenerative adult scoliosis, we can use few of the techniques to help their pain and improve their general function by using the Schroth method. So it does help in quality of life. It decreases the disability level and improves their psychological well-being, and helps in pain control, and also helps in postural balance and movement outcome. So here we see the 24-year-old woman with extremely severe scoliosis, and within 3 months of intensive Schroth method, they were able to have an improvement in the posture and also their breathing ability. And after you can see the picture on the extreme right, where there is much more improvement of the spinal muscle, the position of the spine, and there is much improvement in the spinal muscle strength and stability to keep the posture up. And here we see the pictures of adolescent where with exercises they're able to decrease their spinal curvature by doing physiotherapy exercises that are specific to the spine. So from 32 degrees, there is a decrease to 24 degrees of the thoracic curve. So the principles that we use are self or auto elongation, then frontal and sagittal plane corrections, and we use facilitation of symmetrical muscle activation to stabilize curves and to help understand their best possible alignment. And it involves cognitive, sensory motor, and kinesthetic feedback to the patients. And once this is done, we also integrate these exercises into their daily activities rather than making them to do a specific exercise without functional activity. It will not be effective. So we need to figure out the exercises and make them to do it in a functional way, like the activities that they do in their daily life would be much more appreciated by the patients rather than just giving a mechanical exercise. So basically, when the patient presents with whether they're sagittal plane or with deformities in sagittal plane or deformities in both frontal and transverse planes, such as scoliosis, these methods can be effective. And you can see from the slide where the patient has a lot of scoliosis, and you can also visualize from the deformities from superior angle as well. So the theory behind rotational angular breathing is to improve the mechanics of breathing so that the affected side lung is getting much more air, and to improve the volume on that side, that decreases the asymmetry of the lung expansion and improves the scoliosis posture or the chest deformity. So to improve that rotational angular breathing, the methods that would help us is with derotation and detorsion of the spine and the rib cage, rather than using any kind of repeated movements of flexion or extension. So it is best observed by correction of the posture and realigning the posture according to the neutral alignment of the spine and the pelvis. And then we can bring on the breathing exercises to help improve their posture. Um, Here are some of the common deformities that are seen in the sagittal plane, which are hyperkyphosis, like kyphosis of thoracolumbar spine, or just the lumbar kyphosis, or a spinal inversion where the curvatures of the spine are completely inverted. The place where you should see a kyphosis, you might see a lordotic curve, or in the lumbar spine you might see a kyphotic curve, which is completely opposite to the normal presentation of the spine. Then in the scoliosis deformities, we classify these patients into 4 subgroups. The first one is called as three curve classification, where you see the thoracic prominence on the right. I mean, it can also be, the thoracic prominence also can be on the left side as well, but the most common presentation is right thoracic prominence and lumbar prominence on the left side. And the main characteristic of this classification is the lumbar prominence is the lumbar spine and the pelvis are combined together. In the 4 curve deformity, the lumbar spine and the pelvis are completely derotated, so they're not in fusion. So you would see opposite gliding of the lumbar and the pelvis from the sagittal plane, in the frontal plane. So this is a right 4 curve where you can see right thoracic prominence, left lumbar prominence, and pelvis shifted to the right side. Okay, and then the third subgroup is single thoracic or single lumbar, where you would only see a lumbar prominence or a single thoracic prominence, and rest of the blocks are in normal alignment. And the 4th subgroup is called as not a 3, not a 4, and just shortly called as N3, N4, without any lumbar deviation. It's either with or without lumbar involvement, where the thoracic curve and the lumbar curve are completely balance each other. So you would not be able to see any kind of deviation of the trunk to one side. These patients are very difficult to diagnose unless otherwise you have the radiograph taken for these patients, because they do not present with any kind of topographical asymmetries, because sometimes they are in a very low Cobb angle. It is very difficult to find out if there are any prominences in these patients. So in the Barcelona Scoliosis Physical Therapy School, we do start with pelvis corrections, and then we also start with the lower extremity corrections of weight-bearing transference, and then we go on to do the maximal corrections of the spine. So thinking about the maximal corrections, if we hold a towel where it doesn't have any kind of tension in it, that would be the normal relaxed posture of a person. Whereas if you are creating tension in a towel where you're holding all the 4 corners, where the 4 corners are diagonally given some traction, you would be able to see the tension build up in the center of the towel. So in the same way, we can bring that analogy to the human body by applying the forces from inside to outside, where we are creating the tension through the lower extremities, pelvis, through the spine, and to the rib cage, and to the shoulders, and to the head and neck. You would be able to correct the posture of the body, and then it would create a perfect environment for improving the breathing techniques. So the first technique is called as self-elongation or auto-elongation, where the person is standing on both feet and keeping the pelvis in neutral alignment, and trying to elongate the spine. And then the second technique where we use the asymmetrical sagittal straightening, where uh, the the pairing of forces from ventral and to dorsal are occurring at various levels to bring about much more detorsion and also derotation. Then at the later stage, we bring on the frontal plane corrections, where we're trying to bring containing the prominences inward from the lateral side to the midline, and the deflection and the process of deflection, which is called as where you're trying to open up the concave side of the deformity. So by correcting the spinal deviations, you would be creating a perfect opportunity for the chest to have a good breathing ability to improve the breathing mechanics. And you would be able to reshape the trunk by using the volume control, by using the breathing techniques. And later on, you would use the stabilization technique, where you're trying to hold the corrected posture, say in a short duration for say 30 seconds to 1 minute in the beginning, and then trying to hold it on to like say 2 to 3 minutes, and then progressively increasing it to 5 to 10 minutes. So here in this slide, you can see the expansion contraction technique, which is effective on the left side, where you're able to create additional correction of forces to better reshape the lungs and also the rib cage and the chest by using the expansion contraction technique of breathing. So by correcting the posture and introducing the rotational angular breathing, you would be able to expand outwards and backwards in the areas where of the spine or the rib cage where there is a concavity. And by using the muscle activation techniques, you would be able to contain the prominences of the thoracic or the lumbar humps, and you would be able to bring about like maximal and neutral alignment of the spine. And again, there is no complete reduction of the thoracic or the lumbar spinal curves if the deformities are more matured. There is only an improvement in the posture of the spine, rather than trying to promise the family or the patients that the complete reduction in the Cobb angle would take place, because our aim is to treat the patient holistically rather than trying to reduce the Cobb angle, because most of the time there may not be a complete reduction of the scoliosis or the kyphotic deformities, but you would be able to see a decrease in the Cobb angle, whereby the patient is able to improve functionally and take care of themselves going into adulthood and later stages of their life. So the positive outcomes would depend upon helping the patient to understand their posture and their breathing technique, their breathing pattern, and helping them to understand their exercise program and their commitment to the therapy. Ultimately, it's the patient who can take care of themselves, because you cannot do the exercises for them to help improve their functional level or to decrease the pain. So that those are the important things to keep in mind. And so these are the active and passive some of the exercises, because the first one is where you're is called as a semi-hanging exercise, where the patient is in a partial squat posture by stabilizing both hands on the wall ladder, and they are bringing their pelvis down towards the floor, and you would be able to see the spinal elongation and also corrections taking place in frontal and sagittal plane. So for that, you can include the diaphragmatic breathing techniques that would help improve the breathing mechanics of the patient. Then you can also challenge the sitting position. You can do these exercises in sitting, standing, laying on back, like supine lying. So, and you can also challenge to higher level of exercises by making them to sit on a gymnic or physio ball. You can also use TheraBands or TheraTubes to help improve their forces thereby improving the correction of the spine and the rib cage. Then these are some of the advanced exercises. This first slide, it's about St. Andrew's exercise, where the patient is very highly trained with the breathing technique and also the isometric control of the spinal posture. Then you would be also you can people who are therapists who are well trained in manual therapy techniques or myofascial release. You can do soft tissue mobilization or rib mobilization in these positions, because the patient's back is much more easier for the therapist to apply forces, and you can improve the flexibility of the spine. So these are some of the positions where you can help improve their spine flexibility and help and also coach the breathing technique when you're doing the Schroth therapy. So this is one of the basic starting exercise where you would position the patient in lying position, and we can see the pelvic strap is attached to another strap that is attached to the hook of the wall bar, or you can attach to any hook onto the wall, and patient actively moves away from the wall, which causes like auto elongation of the spine, and then the patient is applying shoulder traction forces on both sides, that's further opening up the weak side and the weak points, and then it would help with maintenance of posture, where he can actively do the breathing technique to improve the chest expansion. Then the exercise here in this position are for side lying. Again, you can use various tactile and sandbags or rice bags to give stimulation to the areas to help them improve their expansion of the muscle, and also activation of spinal muscles to for the spinal elongation to occur. And you can also incorporate this exercise in laying posture when they're sleeping at night. So if they're presenting with a specific spinal deviation, you would be able to advise them which side they need to lay down and the side that needs to be avoided temporarily. And these are some of the advanced exercises where the patient is being challenged in a different position, where it's called as a muscle cylinder exercise. And this is a chest twister, where you're trying to use the poles to help elongate the spine further. And also when at the advanced stage, you don't have to use the poles, and patient can do them individually by themselves. And you can definitely use your physical therapy techniques that you learned in school, such as the myofascial release or any other kinds of manual therapy techniques, in assistance with the breathing exercise and posture correction. So the healing will be much more holistic. And adolescent kids who are using the spinal braces can also do these exercises safely in their brace. So it's much safer to do these exercises in bracing as well. And you can teach them the posture correction and breathing technique in their daily activities. If the kids are into using a music instrument or sitting at the computer doing the school homework, we can incorporate their posture correction into their functional activities. So you can also have work on any kind of bony or soft tissue deviations, or any kind of biomechanical, and also teach the biomechanics of respiration in these self-treatment exercises, where the patients are able to sustain these postures for a long time. So they spend like 5 to 10 minutes in each position of these for the exercises to be effective. So you would be able to work on their bony or any kind of soft tissue impairments, and also work on their mechanics of breathing. Then also, like, we teach them about their sleeping posture, and then like standing in resting stance, or if they're carrying a backpack or a school bag, we have to identify the right kind of technique where they're not so that they're not aggravating the curvature or the spinal deviation. And we need to also teach them spinal neutral spinal techniques where they're not causing too much strain on the spine when they're reaching downwards or reaching overhead cabinets. So this is a simple slide about how a general kid would normally sit in front of a computer. So we can see, from going from left to right, we can see how the person's spine and the pelvis is much more stable in the end, where he's able to sit equally on both of his ischial tubercles, and pelvis and lumbar spine and thoracic and cervical spine are in complete alignment, rather than any kind of deviations in the other slides here. So we teach the patient about their posture based on their spinal deviation and the postural deviations that they present to us. So just a general posture education would be good for the patients, because if keeping it simple would be easy for them to understand and take home, rather than giving too much information. So just talking in lay terms and simple words would help them understand better, and also giving them visual aids and small verbal cues for them to correct their posture would be helpful for them. So in this slide here, you can see where the patient has the trunk completely deviated to her right side, is much more stressful on her spine. But when the patient can be corrected and educated about their posture, here on the right side, you can see the patient has much more aligned position. So again, same thing in the sleeping posture based on this patient's spinal presentation. You can see the one in the bottom photograph. The patient is much more in neutral alignment of the spine. So you have to identify the right kind of clinical presentation to give the right kind of suggestion to the patient. And also, yeah, when explaining the patient in how to carry their backpack, it should not be usually more than 10% of their body weight, but and also identifying which side, if they're carrying on one side, which side is aggravating the spinal deviation or causing more stress on the spine should be identified, and you have to give the specific advice where it is not aggravating the spinal curvature. So this patient has left thoracolumbar convexity. So it is getting much more aggravated if the patient is carrying the back, like the handbag on the right side, whereas if she's carrying on the left side, it is much more straighter, where it's not straining the spine. So the technique how the patients carry out is very specific to each person. Again, functional activities like coming up from the floor, like whether they have to come up on one leg specifically should be explained so that they're able to understand how to functionally maneuver their transition positions from floor to standing. Then evidence about about the exercises in reducing the progression rate, and also exercises are shown to be effective in reducing the brace prescription. So if the patients are able to manage with exercises and breathing techniques, they don't have to be on the spinal braces for a long time. And then it is also found out that prevents spinal deviations, or like it prevents progression of spinal curvatures. This study was done in 2005. So they observed cob angle and vital capacity and muscle strength have improved from 6 weeks to months to 1 year. And in this study, they also have improved conservative methods of treatment with outpatient PT on an intensive basis, and the application of high correction braces are effective in reducing the prevalence of surgery in patients with adolescent idiopathic scoliosis. So posture correction with breathing techniques are much more effective than are effective in preventing surgery rates. Then it's also found out improving pain, respiration, and psychological state. There is a physiotherapy has significantly elevated these primary symptoms on spinal deformity and pulmonary deficiency and pain and psychological issues. So more evidence about active self-elongation exercises and task-oriented exercises of spinal deformities have improves the quality of life. And this is one of the pictures I think we discussed earlier. Yeah. So here we can see how the patient is trained about their posture in side lying, then also given exercises in sitting on floor, and you can also use posture bricks for pelvis support. Then this is an advanced exercise, which is the muscle cylinder exercise, where the patient is well trained to perform them independently by themselves. Here you can also see where the patient is independently performing the exercises at their home, using the principles of the Schroth and the Barcelona Scoliosis Physical Therapy School, and incorporating the breathing techniques. And some of the case studies here, we are able to see a decrease in the cob angle and an improvement in the spinal posture and the alignment of the spine and the pelvis and the lower extremities by using the Schroth method and the breathing techniques. Then these are the before and after pictures of one of this patient with 14-year-old with 8 months of Schroth and basic training. You can see the improvements of their spinal posture from before and after. And this is a case study where this patient was treated for Schoorman kyphosis, and this exercise is called as iguana exercise, and where the patient is using active TheraBand exercises to help strengthen the spinal and shoulder muscles, and also improving their spinal and respiratory mechanics. And here is the radiographic changes of this patient, where you can see the difference in their kyphosis of the thoracic spine. That is, there is a decrease in the kyphosis of the thoracic spine. And this is a 5-year-old patient where they were treated with the Schroth method, and in 2 months, like by week 8, there is a very, very good outcome of posture correction and decrease in the thoracic prominence by doing the exercises of the Schroth method and the breathing techniques. So that's come to an end, and let's open up for Ramki.
Thanks, Teja. Very informative. I think, especially for teenagers, I see a lot of people with issues on their kyphosis as well as scoliosis because of their posture. And I always talk to all my clients about it. And like you all mentioned, posture is the main thing.
Yeah.
What are I have a couple of questions.
Yes.
So one, what are some of the other breathing techniques that you use? Because we talked about more of scoliosis and breathing. Can you demonstrate, if you can, couple of diaphragmatic breathing, or doing with some active movements, so people can benefit from it?
Yeah, so that was one of the, I thought of doing videos and attaching videos to the thing, but it will be much more easier for me to demonstrate in the clinic. But yeah, so first thing is, there is no one perfect breathing technique which is considered superior to another. So, but in a patient where if their respiratory pattern or breathing is causing much more fatigue, or if it is creating inefficient breathing method, then we need to control that by using any of our PNF techniques, uh, so that you can prevent excessive energy um, expenditure by the patient. So you can. So normally, what I teach the patient is by uh, manually placing the hands on the areas where you feel that there is not there is no mechanical expansion of the rib cage, or the if you have any particular lobe or any particular side of the chest that you feel that you're not having a good expansion. um, the technique that I would use is like a manual PNF technique, where I'm giving uh, like a mild to moderate pressure into that area, and uh, asking the patient to breathe into my hands. And this breathing verbal cues and tactile cues would only begin after I have corrected the spinal posture correction. So that would be one technique. Then second one is for the patients to perform by themselves. um, I can give a elastic, like the TheraBand that I can wrap around them. Okay, and they would be able to, like, we have to wrap the TheraBand around their trunk in the areas that we think that they need a tactile cue. So that TheraBand in that, which is in contact with the area that is considered to be weak, or weak point or a weak side, we can ask the patient to breathe into that area where the TheraBand is. So that will give them a tactile cue for them to expand into that area. Then other techniques I would also include is incentive spirometry, where they would be able to like work on their breathing, some because of the scoliosis or spinal deviations, which is a restrictive uh, lung problem. They should be able, so using an incentive spirometer would help them uh, to improve their the breathing technique, and they can take in more volume of air and help in rotational angular breathing. So those are the three simple things that I would be using.
Good.
Um, yeah. Mm.
On, and thank you for that. And the second thing that I wanted to ask you is also the other techniques that you use other than the Scroth method.
Mm.
Like, do you guys use cupping for kids? Have you tried cupping and then massage and educating? I mean, of course, you talked about postural education, so which made more sense with sandbag and stuff. So, do you guys do anything else?
Um, I mean, I do a lot of coordination exercises with them, because patients with spinal deviations and breathing difficulties, they do have coordination issues as well. So I'm not trained in the cupping, or I don't use dry needling, but I use like techniques that would help myofascial release, or I would do Maitland manual therapy techniques to help improve the spinal mobility or rib mobilization. I don't do much of a massage, but the techniques that are involved in myofascial, sometimes they can resemble a massage, because each basically all manual therapy techniques, uh, they're one way or the other, they are all the same, but they're called different names. But I try to use more coordination exercises and myofascial release techniques for the spinal muscles, if I see areas of tightness or areas that needs to be stimulated. And for spinal mobility, I use Maitland manual therapy techniques.
Perfect.
Yeah.
Anyone else with questions? Wait 1 second, Teja.
Sure, no problem.
We'll just wait for somebody to ask questions.
Yes, yeah. No.
Guys, if there's no questions, Thanks, Teja. Once again, Teja is one of the inspirations behind us starting this weekend wellness thing.
Oh,
So
thank you.
we had a talk earlier, and then all of a sudden we started with this program.
Yeah.
So thank you for your presentation and your inspiration to start this.
Yeah.
And with that being said, tomorrow
Mhm.
we are having at 4 o'clock, being Mother's Day. Happy Mother's Day to all the mothers out there. We are going to have Vinod present on dizziness and vertigo symptoms and management. So he's going to work on it. And once again, this is a free session for everyone. Please pass it on to your friends and and family members. We will post this video on Facebook by tonight or tomorrow, and it'll be there for everybody to view. So thank you once again, Teja, for your time. Thanks everyone for attending the session today.
Thank you, Ramki. Thank you for giving me the opportunity. I
Thank
really
you.
appreciate it.
Thanks, Teja.
Thank you.